and welcome to today's Patient Engagement HIT.com webcast sponsored by LexisNexis Risk Solutions Healthcare. Data for Good, the case for operationalizing social determinants of health into clinical models. I am Vanessa Desiato, Project Manager at Xtelligent Healthcare Media and moderator of today's webcast. We will begin with a presentation by our speakers and conclude with a question and answer segment. Audience members can submit questions at any time during the webcast using the question tool to the left of your screens. For all technical matters or difficulties, click the help icon at the bottom of the screen. A recording of the webcast will be made available following this presentation. First, I'd like to thank our sponsor, LexisNexis Risk Solutions Healthcare. The healthcare business of LexisNexis Risk Solutions has mastered the art of combining, analyzing, and delivering data and analytics to optimize quality, performance, and impact across healthcare entities. Their solutions leverage the industry's most robust and accurate provider data, comprehensive public records, proprietary linking and claims analytics, predictive science, and computing platform to transform the business of healthcare. With that, I would like to introduce our speakers, Rich Marino, Senior Director of Vertical Solutions, and Aaron Benson, Senior Director of Market Planning at LexisNexis Risk Solutions Healthcare. Rich, I'll now hand the floor to you.
Thanks, Vanessa. I appreciate the introduction, and thank you all for attending virtually this webinar today. In order to frame today's conversation, I will begin the conversation discussing the impact that social determinants has on patient engagement. Then Aaron and I will collaborate on the topic of creating value in the workflow. So in order to understand the potential impact on patient engagement, it's best by starting and examining the state of the healthcare industry prior to COVID-19, that is. That will give us some insight into what trends needed to be addressed and helps frame and how we will determine if the right impact was being made. Later in the presentation, however, we will touch on the ramifications of COVID-19 and the impact patient engagement has, as well as the role of social determinants of health. We've all heard about the unsustainable cost trend in healthcare. This trend has been associated with the use of our pre-negotiated a la carte menu for services, otherwise known as the fee-for-service model. One effort that gained a lot of momentum to rein in this trend was a move towards pay for performance, which was an attempt to move from paying for service to paying for quality. However, in the early days of these programs, most of the focus was on process measures instead of treatment or satisfaction. So it was dubious as whether or not a significant enough impact was being made. Additionally, most of the bonuses that were supposed to drive physician and provider behavior occurred long after the physician or provider had taken action, causing the awarded physicians to wonder what it was they did that actually led to these payments. However, a lot of the building blocks for the pay-for-value movement were built out during this pay-for-performance phase. Today, we benefit from the work done by NCQA on HEDIS, CMS on STAR, MACRA, and Pioneer ACOs. And while these efforts led to a broad adoption of population health, they also helped highlight research that closing gaps on a certain at-risk population was the difference between high or low score, with the financial ramifications associated with your ultimate scores. We call this focus on that population which drives your score population movers. You can't see, but I just did air quotes around population movers. And this is a group that has chronic conditions that led to a lot of medical expense, but also could be engaged in managing their own care. Movers indicates that they're not stuck in their current state and can be targeted successfully for patient engagement efforts associated with pay for value. Now let's dig into the concept of movers in a bit more detail. It isn't hard to identify which members of chronic conditions that have led to expensive and ongoing care. Most health systems and health plans have teams already dedicated to outreach and coordination with this population's health. So why aren't we making a bigger impact? The answer lies on this slide. It's estimated that quality of care only impacts 20% of an individual's overall health outcomes. Additional 20% comes from the genetics of that individual. That leaves 60% of the impact of outcomes that are based on social, economic, and behavioral decisions. An excellent example of this is hospital readmissions. Excellent care can be delivered, But if the patient is discharged to a home where they're socially isolated, lack transportation, and have low health literacy, odds are quite high that they're going to return again in 30 days. We've all heard the well-known population health statistics before we even touch the ones on this slide. And that is that the top 5% of a population's medical users account for 50% of the overall costs. What's more, the very top 1% account alone for 20% of the costs. This has led to an intense effort to coordinate these at-risk individuals' care to ensure they improve or at least maintain their current health conditions and don't deteriorate. This is critical in the world of pay for value, where both health systems and health plans are incented to reduce readmissions and close gaps. This is where social determinants of health can make a huge impact. Not only can understanding the patient's social and economic situation enable better predictions of risk, it also allows care coordinators to know what needs to be included in a care plan. For instance, you might have a plan that calls for weekly outreach to make sure that insulin is being taken and weight being measured. However, knowing that they're socially isolated without transportation and live in a food desert, you might want to check to see if Meals on Wheels can deliver produce so lack of nutrients doesn't further exacerbate their condition. Well, much of what we've discussed at this point is how a population health can go ahead and be trained to impact pay for value, how social determinants of health is a key ingredient to understand and prioritize resources on risky populations, along with understanding who are your movers that can impact clinical quality improvement scores. So let's spend a minute on the elephant in the room, COVID-19, and how social determinants of health and patient engagement can make an impact. The first thing we see up here is at-risk populations, followed by socioeconomic barriers to health exacerbated by COVID-19, and following discussion on the post-COVID-19 world. With testing and treatment capacity currently still ramping up to handle our entire population, we see a lot of efforts being made to target certain populations who are probably significantly at risk. These are typically patients who already have some type of combination of clinical factors. Let's say they have COPD and respiratory issues, and social determinants of health factors, say living in transient housing and potentially being economically unstable. A lot of research these days identifies these types of population as being particularly at risk for catching COVID-19, and outreach to them and testing them and seeing what we can do to improve their situation might prevent that from occurring. Finally, social determinants of health is being used to help us prepare for a post-COVID-19 world, such as identifying those at risk who are unlikely to come into the pandemic due to fear of catching the virus. While a portion of these individuals today can successfully manage their conditions remotely, many patients lack the social and economic ability to do so, and will see their health deteriorate as the pandemic goes on. For instance, individuals with housing and economic instability might mean an inability to use telehealth or patient portals for communication and coordination of their care. A focus can be made on outreach prioritization of these members to bring in immediately once the pandemic subsides. This brings us to the first poll question of the day. Is your organization considering social determinants of health in the response to COVID-19? The potential answers are yes, no, we plan to, no, and we don't plan to, or that right now that is unknown. We'll give it a minute here for everyone to go ahead and select an answer, and then we'll review the poll results together. Give it a few more seconds for all of you to decide which of these responses might most appropriately reflect your organization. And now let's go ahead and see what the results are. So over 2/3 of you indicate that your organization is using social determinants of health currently in their response to COVID-19. And that's outstanding. Hopefully the conversation we're having right now on the previous slide, as well as what we're going to contain, might offer additional tips or confirmation of the path you're taking. For the almost 11% of you who are contemplating figuring out how to do that, this might serve as a blueprint for you. And for the rest of you, hopefully this is something you could kick back and digest and see whether or not it might change the way you view your battle against the COVID-19 virus. So let's continue on with our topic here. There's been a lot of discussion about what is social determinants of health data and how can you get use out of it. Well, for the third year in a row, we here at LexisNexis Risk Solutions, healthcare division, have conducted focus groups with CIOs and technology leaders across all healthcare, all CHIME members. And while we heard that most healthcare organizations collect data at the point of care via surveys, there are still several areas for improvement. Now, one of the areas that was highlighted is that surveys have weaknesses. Patients may be unable or unwilling to provide details. For example, they may be reticent to admit food insecurity issues. Some of our clients have actually seen this in regards to seeing that the input address that a patient had indicated they live at was actually a vacant plot of property, a vacant lot. And that usually is indicated that they're too embarrassed to let you know that they might be having housing issues. There's always the issue with fat fingering and manual data entry of survey responses. But the big concern in regards to use of survey data is it's estimated that only 4% of commercial members annually fill out health risk assessments, leaving the overwhelming majority of your population unaddressed. So not knowing where to prioritize your resources because you only have insight to a small subset leaves the organization inefficient use of their resources. And again, last point on surveys, they're heavily relying on, especially within the health systems, a consistent provider interaction. And if the patient isn't coming in routinely or engaging with the provider, there's not an opportunity to collect that. And that's especially exacerbated with primary care physicians when the member doesn't necessarily allow them to coordinate their care. If they have a bone issue, they might go to an orthopedic. If they have an allergy issue, they might go to an allergist, so on and so forth, without any of that information being physically shared with their primary care physician. So far we've discussed the move to pay to value, how population health plays an important role, how social determinants of health can help you identify who's at risk, and help inform what type of action plans are required to help mitigate that risk. So now let's transition a little bit to how to leverage this insight within your workflow. LexisNexis Healthcare is proud to be a member of EHI's collaboration project on the ethical use of social determinants of health. This is important because the data which can provide critical insights into how to improve care can also be sensitive personal information and needs to be treated appropriately and only utilized for the purpose of care improvement. Now, underneath care improvement use case, there are 4 subcategories that we're going to discuss. Recognizing health and wellness risks through social determinants of health analytics, mapping community resources and identifying gaps, care coordination, the customization of health services interventions, and service and impact assessment. So let's dig into recognizing health, wellness, and risk through social determinants of health analytics. This is the first stage, and the stage is typically managed by quality and analytic departments. Most systems and plans already have some clinically focused models that they utilize today. And during this stage, what they're evaluating is such questions as, do we want to supplement our clinical models with scores built only from socioeconomic data? Or do we want to combine socioeconomic data and clinical data for new predictive models? Now, the answer to these 2 questions oftentimes is decided by the availability of your analytic resources, if we're being candid, because both could be deployed successfully. Additional question, which targets conditions are impacted by social determinants of health? Some conditions, let's say, for instance, knee replacement, are more heavily influenced by genetics than social economic conditions. Early efforts at combining social determinants of health data into clinical models really focused on potential lift also. And while that's certainly a value and a good outcome of including social determinants of health data into your predictive models, what current efforts are highlighting is that it's even more impactful result as understanding why someone might be at risk. This understanding of why someone might be at risk is accomplished through combining insights from multiple categories of social determinants of health. Now, neighborhood information might inform us that our patient or member lives in a food desert with lots of transients and low income. However, social and community context can tell us they live in a large household and own several cars. Education can tell us that they're likely health literate, and economic stability could indicate that the spouse makes well over 6 figures, indicating that household is very likely just simply living in a gentrifying neighborhood, that they're not near poverty, which the census neighborhood information alone would have inferred. This understanding of why someone is at risk is crucial to the success of any social determinants of health effort. Current quality and analytic departments are either combining socioeconomic attributes or data with their clinical data to predict who's at risk, and then choosing select data to inform care management why they're at risk, or they're using pre-built scores based only on social determinants of health information that include insight into why someone scored as a high risk. For instance, they're socially isolated, their nearest relatives were 500 miles away, and economically unstable. Additionally, on this right side of the screen right here, socioeconomic health scores, you see some examples of predictive targets which are heavily influenced, i.e. the lift is dramatically increased by inclusion of social determinants of health data. So how do we get started? Well, just as we learned that social determinants of health identifies not only who's at risk, but why, we also had new learnings on turning potential into value. Oftentimes, social determinants of health projects would stratify their entire population, reveal who's at risk, why, and where they lived. The question then became, what do I do with all this insight to turn into value? And more often, the answer is following the mantra, think globally but act locally. Global means identify which conditions and where are prevalent in your population. Form a multi-year strategy to decide which conditions you can align with the social service and when. But in the short run, focus on members where you already have a social service in their community that can address the specific barrier to their health, such as someone with a high risk of readmission who has no access to transportation, and your system or plan has non-emergency transportation set up in their geography. Now, a good place to start and look is your clinical quality improvement programs, because oftentimes these have a few services already set up to help them with improving and closing their gaps in care, hence improving their clinical quality scores. The next step in the care journey is mapping community resources and identifying gaps. On our previous slide, we discussed acting locally, aligning with existing resources. This stage in the care journey is more strategic, though. Which socioeconomic barriers to health reside and where? Which social services are already available in that community? Does it make sense to align with those existing services to make them scalable and sustainable for your population? Or does the concentration of members in a certain geography indicate that building out your own services make a lot more sense? We then move to the next stage, which is care coordination. In order to measure success at this stage, we need to determine which patients or members participated in the recommended interventions. Questions such as, were we able to reach member to coordinate their services? Did that patient or member utilize the service? And how likely is that member to participate in managing their own health? Now, this last question often turns into an analytic model. Who is motivated to participate in their own care? And what would prevent them from managing their own care? Knowing that information ahead of time before your outreach is exceptionally useful in the hands of your clinical care coordinators. This brings us to the final stage, service and impact assessment. While most health plans and systems have begun some social determinants of health efforts, the ability to continue them or scale them are largely dependent on showing some positive return. Now, return can mean a variety of different things. For instance, it could be measuring cost avoidance. It could be measuring the number of patients that were successfully engaged. It could be a demonstration of the impact on quality ratings, which are tied to financial measures. And finally, on whether it improves the bottom line. While most systems and plans view population health efforts such as social determinants of health as strategic and part of their mission, Like any other project, they compete for resources. So the better answer we have for service impact, the more likely you're able to go ahead and scale this particular project. Now, earlier, again, we discussed that acting locally and tying your efforts to clinical quality improvement to justify impact and measure ROI. On this slide are some examples of measurements that health plans are already measured on, and they're very similar to the MIPS scores for health systems as well. On the left are common HEDIS measures. On the right shows 3 of the 5-star domains that are associated with the health plans, and they're very similar. Frequently, health plans start their social determinants of health projects by seeing what impact can be made on these measures and use that impact to justify further investment. If we start by examining the process measures associated with prevention, we see many systems and plans are starting to use a motivation model that can predict who will come in for preventative screenings, such as breast cancer, and will likely need some, or those who are more likely need some obstacle removed in order to close that gap. They're also trying to find out for, they're trying to address outcome measures such as readmission risk models, understand who they should target proactively to make sure they're managing their health post-discharge and do not return to the ER the next 30 days. And this right here, this slide right here reflects some of that information right now. The process measures, which equates to STAR domain staying healthy, understand the individual's motivation to care for their own. And if they show that they have some chronic conditions, but also have a decent degree of motivation, you could probably convince them to manage their own health through some simple reminders such as postcards. However, if their motivation is a little more at risk, you might want to see whether or not transportation, social isolation, health literacy, or some other health barrier is impacting that score and utilize that as insight to engage this member and participating in the preventative screening and closing that gap. This brings us to the second poll question of our webinar today. Where has your organization integrated the use of social determinants of health most? The first answer is social determinants of health risk analytics. The second is community resource gap analysis. The third is care coordination. Fourth option, all of the above. And of course, our fifth option would be none of the above. I'd like to give you all about 30 seconds to go ahead and read these questions and make your decision. We'll take a look at some of the results. Okay. Hopefully most of you have had a chance to make a selection, so let's go to see what the results say. With just over 1/3 of the population, care coordination seems to be where social determinants of health is being deployed the most. And that makes a lot of sense because tying that to a service and managing and developing a care plan for these individuals is where you're going to see the most impact. Now, obviously, all of these are crucial to overall success. The analytics will inform us on who and why, the community resource gap analysis to understand what services we need ultimately, and then the care coordination, the uniting of the who and the why from analytics with the social service and community resources. So thank you for participating in this poll. Now I'll turn it on to Erin to talk about a business case for using social determinants of health.
Great, thanks, Rich. I think that's really interesting to talk through where social determinants can be integrated into workflow. The next most common question that I get about social determinants of health is, how do I quantify the value? This seems to be a struggle that I've seen across healthcare organizations as they look to incorporate this into their workflows, is looking to create that business case and find the support with numbers that they need in order to get various stakeholders on board. So we want to address that today. Organizations are looking to be able to show that other organizations went first and saw value. This poses a challenge because the use of social determinants of health data is still relatively new within the U.S. healthcare industry. But it also poses tremendous opportunity for healthcare organizations to figure it out early because they can gain competitive advantage and, of course, better help their patients. So during the rest of our time today, I want to walk through 2 examples of ways to build a business case that ties social determinants of health data to financial results. We'll start by looking at the potential value that can be achieved by using social determinants of health data to reduce hospital readmissions. Now, as I say that, I want to add an official disclaimer, which Rich alluded to earlier, which is that this case was built when we're still considering a non-coronavirus impacted world. I understand readmission rates right now are not really following normal trends, but these examples should still be useful for preparing for a post-coronavirus world. So we'll go through them, but keep in mind, I realize this may not reflect currently what's happening in the hospital system. So under non-pandemic circumstances, reducing readmissions impacts quality measures under HEDIS, MACRA, the Hospital Readmissions Reduction Program, and other value-based care incentive programs. So it's important to keep those readmission rates low to avoid financial penalties and to maximize reimbursements. We'll look at how social determinants of health information can be used in workflow, and then we'll quantify the value of a readmissions reduction program to give you an idea of how it can be done. So to do this, we'll look at a scenario where we have 4 male patients who are admitted to the hospital with heart failure. Studies have shown that the average rate of readmission is 20% across conditions, but for heart failure, that rate rises to 25%, meaning that statistically, one of these 4 gentlemen will wind up back in the hospital within 30 days. But when they have the same age, the same gender, and the same condition, who is it likely to be and how can it be prevented? Traditional medical care would say they have the same risk and treat them with the same care program, but social determinants of health explain why looking at the bigger picture is needed. Our team of data scientists at LexisNexis Risk Solutions have evaluated hundreds of social determinants of health attributes, and they've looked for correlations to actual readmissions that occurred in historical claims data. One of the many correlations they found is that address history, which is an indicator of housing stability, correlates with whether or not an individual is likely to be readmitted within 30 days of discharge. The longer an individual stayed at the same address, the less likely they were to get readmitted to the hospital. This makes sense when you consider that a key part of not getting readmitted to the hospital is having a stable place to recover at home. Knowing the challenge is part of the equation, but then healthcare organizations need to solve it. One study evaluated the impact that providing medical respite housing to people experiencing homelessness in New Haven, Connecticut had on readmission rates. The hospital system was able to reduce readmission rates 6 to 14% for homeless patients over 3 years, with an estimated savings of $12,000 per patient across all Medicaid claims in the year following respite. So this clearly shows that if you start to address social determinants, there is value to be achieved as well as helping patients. Another one of the many correlations that data scientists found between social determinants of health data and likelihood of readmissions is that phone history correlates with whether or not an individual is likely to be readmitted within 30 days of discharge. The more consistent a patient's access to a phone, the less likely they were to get readmitted to the hospital. One external study looked at the effect of post-discharge follow-ups by phone on hospital readmissions and found that the receipt of a call after discharge was associated with reduced rates of readmission. In fact, members who received a discharge call within 14 days of leaving the hospital were 23.1% less likely to be readmitted than those that didn't receive a call. While there may not be a silver bullet to addressing social determinants of health, the work done by our data scientists at LexisNexis has shown that certain health outcomes can be predicted by social determinants of health. External studies show that addressing these social determinants of health can have positive impacts on health outcomes, which in turn improve those key quality scores and your organization's bottom line. When we talk about using social determinants of health data in workflow, we mean using it to predict who is likely to need help and what kind of help they're likely to need so that those needs can be proactively addressed before a negative health outcome, like a readmission, occurs. This can start at the global or population level, as Rich mentioned. For example, healthcare organizations can utilize socioeconomic data to stratify the risk of readmission within their patient population so that they understand what types of needs exist. This can help with creating programs or forming community partnerships to get those patients the help they need before they end up getting readmitted. Within one sample member population, we saw that for members with medium to high risk of being readmitted to the hospital, about 1,200 had phone access challenges and about 350 had address stability challenges. So if you knew those needs existed within your population and you knew that addressing their phone and address stability needs could help prevent those readmissions, wouldn't it make sense to help those individuals find housing or reliable access to a phone? Once again, as Rich mentioned, global ties to local. When you drill into the data and look at each individual's needs, you start to see where there is need from a social determinants perspective. So if you recall from a few slides back, we said one of our 4 patients had been likely to be admitted with heart failure, was likely to end up back in the hospital. Based on a socioeconomic readmission risk score assessment, it turns out that Greg Johnson has the highest likelihood of the 4 gentlemen at 71% of being readmitted. So that leads to the question of how do we prevent this? And that's where understanding his specific social determinant barriers are driving that risk, and that's how you can start to address his needs. An analysis of Greg's social determinants of health care gaps revealed that he has had a high degree of housing purchase activity, which means he's moving a lot and likely doesn't have access to stable housing. He also has had phone access challenges. So our 2 examples from before showed studies where addressing these 2 social determinants of health areas could lead to better health outcomes. A third area of need is education, revealing he may need someone to spend more time with him explaining how to take his medications and follow other care instructions. We'll look at an example where this can be successfully addressed in a minute. By addressing these social determinants for Greg, it's possible to help him to avoid being readmitted to the hospital. While this shows you how socioeconomic data can be helpful in workflow, we want to look at some numbers that show the potential return on investment in addressing social determinants of health. When you start to build a business case for putting together social determinants of health programs to prevent readmissions, it's good to start with an understanding of the cost of those readmissions that you're trying to avoid. In this example, let's assume there are 1,200 heart failure patients in a Medicare plan. Studies have shown that about 25% of those patients are likely to get readmitted to the hospital, which equates to about 300 readmissions. If we use an industry average of $12,600 per readmission, that means that those 300 readmissions are costing the healthcare system $3.78 million annually. For purposes of this example, I'm using industry averages and numbers from external studies, but please feel free to use the same path to plug in your organization's numbers where applicable if you want to see how much your organization could benefit from social determinants of health programs. The next step in building a business case is to consider the cost of the readmission prevention program. There are a lot of different potential methods to deploy depending on the patient's needs, but if education is a challenge, like it was for our patient Greg, one possible option is to teach them what they need to do post-discharge, and then have the patient teach it back to the care provider to ensure understanding and to help with retention. This is what one hospital system tried, and you'll soon see that it had very positive results. If we assume it takes about 1 hour per patient to complete this teach-back process, we can estimate that it costs about $33 on a staff member's time. This would equate to $39,600 to do this with all 1,200 admitted patients. Again, you are welcome to plug in your own costs associated with your program. So the last step in building a business case is to calculate the potential savings of a readmission reduction program. UCSF Medical Center program found that their teach-back methodology cut readmission rates by 30%. So we'll use that same rate of reduction in our example. Assuming similar reduction in our readmission rates for our population, of the 300 likely readmissions, we could have prevented 90 of them with a teach-back program. At $12,600 per readmission, that's a savings of $1.134 million across those 90 patients. Even removing the cost of the readmission prevention program, the savings is still over $1 million. That's a 29% lift in cost savings, showing how impactful addressing the individual social determinants of health needs around education can be at reducing overall costs. Next, we'll work through a second example of building a business case, and this time we'll focus on using social determinants of health data to improve medication adherence rates for patients. This can positively impact value-based quality programs, including star ratings, too. In this scenario, we'll again look at 4 gentlemen of approximately the same age. This new set of patients have been prescribed medications for the same chronic condition. Statistically, 20 to 30% of prescriptions are never filled, and 50% of medications for chronic diseases are not taken as prescribed. That means that if we look at these 4 patients, 2 of them are statistically likely to not take their medications the way their doctor intended. With any claims or without any claims history, traditional medical care would again try to treat them the same way as if they had the same risk. But looking at their social determinants helps explain why they might not adhere to their medications the same way. Just like with readmissions, our team of data scientists at LexisNexis found correlations between social terms of health attributes and actual medication adherence rates. One correlation of the many they found shows that financial health correlates with whether or not an individual is likely to be adherent to their medications. Adherence was designated as adherent 80% of the time or more based on industry standards. This correlation makes sense when you consider the cost of prescriptions is often cited as a primary reason patients are not adherent. A study done by Express Scripts looked at the impact that enrolling an individual in financial assistance programs could have on improving adherence and found that patients with inflammatory conditions that were enrolled in a financial assistance program saw a 7% improvement in adherence compared to patients that were not enrolled. Another correlation found by our data scientists shows that distance to a nearest relative or associate also correlates to whether or not an individual is likely to adhere to their medications. It turns out that if your nearest relative or associate lives more than 25 miles away, you're less likely to take your medications as prescribed. This makes sense when you consider it may be harder for patients to get their prescriptions if they don't have social support nearby. A review of 50 studies found a greater degree of practical support such as medication help with household functions like cleaning and cooking, and help with transportation was most consistently associated with greater medication adherence. So just like with the readmission prevention programs, a good place to start with medication adherence improvement programs based on addressing social terms of health is to look global at that population level. In one sample member population, about 2,000 members had financial health challenges and about 350 had social support challenges, among those that were least likely to adhere to their medications. Knowing now how these social determinant challenges can impact medication adherence, it would be a great place to start for helping patients to improve medication adherence rates. Within a population health, care management, or EHR system, a medication adherence score could be presented to a care manager, a social worker, a care provider, or a pharmacist that predicts the likelihood of each member to adhere to their medications over the next 12 months based on their social determinants of health, with 100% being here all the time and 0% being adherent none of the time. Thinking back to our 4 patients from before, you can see here, Jack is only likely to adhere to his medications 25% or a fourth of the time. He has the highest risk for non-adherence, although Mani also has had some social determinants challenges that raise his risk. While not the patient with the highest risk of non-adherence, since Mani is likely to be adherent 68% of the time, he may be an excellent candidate for medication adherence programs. Looking at individuals like Mani who are closer to the 80% adherence rate can be especially helpful for improving quality ratings around medication adherence, because small care changes may be able to help these individuals just south of 80% adherence to reach that desired adherence level more quickly. This could be a great way to improve star ratings. So let's look at his specific social determinants needs. Mani shows some indicators of financial health and social support challenges as we talked about before. He also shows some challenges related to transportation access, which may mean he doesn't have a reliable way of getting to the pharmacy to pick up his medication. This could be addressed by having his prescriptions mailed to him. Addressing these social determinants can help him improve his medication adherence rates and positively impact the healthcare system's bottom line. Let's look at the potential benefits quantitatively. As before, we start with the cost. If we assume that there are 12,000 average adult diabetes patients in an average health plan, and that 75% of the population is adherent on average, that means that about 3,000 of those members are not taking their medications as prescribed at least 80% of the time. If the average increase in cost per member for medication non-adherence is $1,600, that means the total annual cost of medication non-adherence is $4.8 million a year. So clearly, there's room for improvement. Although there are many ways to address medication adherence, for this example, we'll look at the impact of a value-based benefit design program that's designed to lower medication costs. In this model, medication co-payments were set based on clinical value rather than acquisition costs because pricing based on acquisition costs was leading to suboptimal use. Using the Health Alliance Medical Plans program as a benchmark, we can calculate the average cost of the program based on the average reduction in price on a 30-day supply of medication, which equated to about $68 per patient. That means that applying this program to our example population would cost $816,000 across the 12,000 diabetes patients. So are the results worth it? To answer that, we complete the analysis by looking at the potential cost savings. The percent reduction in non-adherent patients was 30% in the external study as a result of the value-based benefit design program. So if we apply this outcome to our sample population, that would mean 900 new patients are newly considered adherent, which could result in an estimated savings of about $1.44 million in non-adherence costs a year. Even after accounting for the cost of the program, there's still over $600,000 of savings expected, equivalent to a 13% lift in cost savings. This again shows how impactful addressing the individual's social determinants of health needs, this time around financial health, can be at reducing costs. The patient's health improves, and the healthcare system sees cost reductions overall, so it's a win-win. I hope these examples have given you some ideas of ways that you can quantify the potential value of social determinants of health when you're building out your business case for your own programs. There are many studies out there using a lot of different techniques around addressing social determinants of health that can act as a benchmark for potential results when you're trying to calculate the potential value. So I'm interested now to hear what you have taken away from today's webinar, so we'll move to our last poll. The question is, after today's webinar, which of these activities do you feel more comfortable with related to achieving value with social determinants of health data? Understanding SDOH impact on patient engagement, understanding areas where SDOH can be integrated into workflow, calculating the value addressing social determinants of health derived, two or more of the above, or other. I'll give you a couple seconds to respond. And we'll move to the results. I'm thrilled to see that the majority of you chose two or more of the above. That was certainly rich in my goals for today, and we're happy to continue the conversation and look forward to answering your questions in a few minutes. But it looks like there's a good split between the other areas as well. Certainly, we want to help as much as possible all of the organizations to figure out how to best use social determinants of health in workflow and to really quantify that value. We think that's really important to getting to the next stage of helping to improve overall population health. So as we start to close out today and get towards our Q&A, I just want to say that however you choose to begin using social determinants, there's value to be gained. Hospital costs for readmissions exceed $41 billion a year, and it's estimated that challenges with medication adherence cost the U.S. healthcare system anywhere from $100 to $400 billion a year. So there's a lot of potential savings. And those are just two of the many areas that social determinants could help to improve. It's also estimated that social determinants of health lead to 1 in 3 deaths a year. So addressing social determinants of health is in line with the mission of healthcare organizations to improve the health outcomes of their patients. So let's review just a few final key takeaways before we get to our Q&A. First, Rich went through the ethical uses of social determinants of health and talked about why different stakeholders are involved. Success may not be defined the same way for all the stakeholders in your organization, so it's important to consider and measure what matters to each when you're building a business case. Addressing social determinants of health needs to help to improve ratings under pay-for-performance programs, which can help healthcare organizations maximize reimbursements and avoid penalties. There are many examples and studies that have been conducted that you can use to estimate potential results of addressing social determinants of health. Potential cost savings is one measurement you can start looking at right away, even as it may take a little bit longer to realize the benefits from improving quality ratings. Finally, and we can't emphasize this enough, but we know there are so many options when it comes to addressing social determinants that it can be hard to figure out where to start. We suggest starting with clinically validated social determinants of health data to evaluate needs at the population and individual level to make some key decisions about which health outcomes to address and what types of programs to use. and to use that data to ask your patients and members quality questions so that you can jointly decide where they should really be able to benefit from social determinants of health support. In all cases, the most important thing is to begin. You can always add programs later. So start with a manageable goal and program and expand from there. So Rich and I want to thank you for your time today and hope you found our experience to be helpful. And we're now going to turn it back over to Nessa to open up the session for your questions.
Thank you so much. We will now move on to the Q&A portion of the webcast. Audience members can submit questions using the question tool to the left of the screen. For your first question, how do you see pharmacists play a role in social determinants of health in prior and post-COVID-19?
Yeah, I can take this one.
Karen? Go ahead.
Certainly thanks, Rich. Prior to COVID-19, we were already starting to have conversations with pharmacists about using social determinants of health at the population level as they were trying to figure out the best places to allocate resources to the different stores and make sure that they were properly covering the social determinants needs. And we were starting to see an interest in using it at the store level to determine where they should spend some additional time doing consultations or where they might want to look to do some mail deliveries and things like that based on social determinants needs. I think now that we're in the COVID-19 world, it's becoming even more important. In some cases, the pharmacy is the main touch point that is still happening with patients, so they have an opportunity to see how they're doing. And certainly as COVID-19 has had an impact on the economy, social determinants of health have had an even bigger impact on a lot of individuals, so it's been an increased need. Rich, do you want to add to that?
I thought that was an excellent answer, Aaron. I would just add in the pre-COVID-19 world, we saw not all, but a lot of pharmacies trying to move to a retail clinic type environment where they're bringing more people in for the non-severe treatments of issues. And in that manner, there's such clinical quality measures there as medication therapy management for comprehensive medical review, right? Where you want to get people in with chronic patients in at least annually, if not quarterly, and to review the prescription and their prescription plan. And things like medication adherence and motivation type models that are heavily influenced by social determinants of health can help you identify those who are likely to come on in, susceptible to some initial outreach, versus those that will require a more significant intervention to get them to come in and get that gap closed. So we are seeing in the pre-COVID-19 world a significant adoption and interest in those types of social health capabilities.
Thank you both. And I do want to mention that any questions that we don't get to will be followed up on. For your next question, how useful is zip code as a proxy for social determinants of health?
Rich, do you want to take that one?
I'm switching the speaker on that. Can you repeat that question? Apparently my headset was having issues there, so I switched to speakerphone. Can you repeat the question?
Of course. How useful is zip code as a proxy for social determinants of health?
Yeah, apparently it's not my headset. How useful
I can take this one while Rich figures it out.
All right.
So, zip code is certainly an important aspect because it speaks to the neighborhood and built environment for an individual. So where an individual lives does impact their social determinants of health. But if you were to look at, the guidelines from the World Health Organization and the CDC, neighborhood and built environment is just one aspect of a person's social determinants of health. You also need to look at their economic situation, their educational background, their social support and community context. And there's even other more specific aspects about looking at a person's neighborhood than just the zip code they live in. In some areas, especially in metro areas like Atlanta, the same zip code could have, high-end residential housing, and it could also have, economic support housing. So it's not necessarily a good proxy for what that individual is facing. So we recommend getting really more down to the individual's level and really looking for more specific information than just zip code when trying to assess an individual's social determinants of health to make sure that you're getting them the right care that they need.
Thank you. You may have touched on this a bit already, but what is the most effective way to capture social determinant of health data points?
Yeah, so there's a number of ways that you can capture it. We recommend using, a vendor that can provide public health or public records-based information because that tends to be very reliable. It can be frequently updated. It's consistently formatted and provided out to you, so it's something that can be used regularly and updated over time. It's also important to look at longitudinal information. For example, when you consider someone's income, it's not actually their current income that has the biggest impact on them, but how that income has changed over time. So if they've had a dramatic decrease in income, that probably has created a lot of stress in their life, which can actually be an indicator of a social determinants of health challenge that they're facing, even if it doesn't seem like the income is that low. It's the change over time that can have the impact. So we recommend looking both current data, longitudinal data, as well as finding a way where it can be consistently provided, updated, and evaluated. Now, I also hear a lot of times that organizations will use surveys asking the patient directly, and we recommend starting with a tool that's based on kind of more of that public records type data, but then based on the outcomes of that, using that to direct the care provider on the places in the survey to really focus, so that they're asking their patients about the most relevant questions that are likely impacting their life. And that can be the start of a really quality conversation with that patient to determine what kind of help they need versus trying to ask every survey question when some of them may not be relevant. So the two can work in tandem really well to help to really zero in on where the patient might need the most help in the very efficient a manner that providers have to address it in today.
Thank you. Do you know if any good intake assessments have been developed yet to gather information about social determinants of health in the EHR?
Yeah, so we don't necessarily have any recommendations specific to the intake process, but again, being able to use data from public records, that's actually something that could be pre-populated and easily pulled up on an individual at the point of intake so that they are able to quickly assess what needs that patient might have.
I'll add something to this because I think, at least I'm crossing my fingers temporarily, my connection has improved. We talked earlier about a pre-COVID and post-COVID-19 world, and this is my not working from my home office and the cellular reception as a result of COVID-19, right? But the question was, what intake assessments have been developed which you think could gather good information about social determinants of health? All of them, there's a variety of them. I know the PROPARE, I don't know if I'm saying that right because I'm missing a vowel, is widely adopted. Where we're seeing a lot of work, actually, is the use of objective third-party social determinants of data, for instance, from public records and so forth, to inform physicians on which SDOH questions to ask. So rather than asking the questions and recording them, assessing the population before they show up for an interaction and knowing that there might be a condition such as social isolation or lack of transportation or economic instability, so that the physician could capture that in the form of some type of field in the EHR or in the use of a Z code, which could be recorded and utilized. What we're seeing heavily is that without that kind of lead or instigator or trigger, oftentimes that information is not asked or collected at the point of the patient-physician interaction.
Great, thank you both. What types of commercial products are proving to be successful for healthcare systems to employ?
What types of commercial products?
Yeah.
I'm not sure that we have a recommendation specifically on that, but I would say specific to understanding social determinants of health needs, that the important thing is to look for either clinically validated attributes that you your analytics teams or your predictive modeling teams can use in their, their modeling when they're creating different models that they use throughout their organization, or to look for an organization that has predictive scores that they have already clinically validated in order to best enable that to be used directly by the care providers and to get that information out to the organization as quickly as possible. You heard me say clinically validated in both cases. It's really important to make sure that that information isn't just sort of a data dump of general demographic data, but that it's actually been shown to correlate to specific health outcomes in order to make sure that it's the most efficient data that's being used within the organization to best impact the patients.
Thank you. Why is it important to look at individual care drivers or certain risk scores when factoring social determinants into clinical models?
So specifically, care drivers is a term that we use at LexisNexis that basically is just a bunch of subcategories of social determinants of health that can provide some really good areas to address risk for a patient. So it could be anything from, transportation access challenges to social support challenges to financial health challenges. And the reason that's important is because an individual's needs and what they specifically need to address from a social determinants perspective may vary. And specifically, too, when you think about it, I think sometimes we tend to think social determinants only impact certain populations, but the truth is every single one of us is impacted by social determinants of health. So it's really important for care providers to take that into consideration with every patient they're looking at. They may do more for the patients where they're seeing higher risk as a result of those social determinants, but it's certainly important to understand it across the board because patients need to be treated holistically in order to achieve the most optimum outcomes.
Thank you so much. That concludes today's Patient Engagement HIT.com presentation. As a reminder, any questions that we did not get to, we will address after the event. Special thanks to our speakers, Rich and Erin, our audience, and our sponsor, LexisNexis Risk Solutions Healthcare. Thank you and goodbye.